Okay. I apologize for the bad camera quality. I've never used this before. So today I'm going to be giving my presentation of our case study. The patient information, 64-year-old male, height 6'1", weight 136 kilograms, which is 299 pounds. Reason for coming in, shortness of breath, wheezing, runny nose, congestion, and a productive cough. Admitted diagnosis was right lower lobe pneumonia and right pleural effusion. The clinical proof of that, the CXR showed patchy infiltrates in the right lower lobe. So basically, this patient was coming into the clinic for a wound checkup. The patient had had a fall at home and needed stitches on his chest on the right side. He reported having increased shortness of breath and breathing issues. He was running a 100.8 temp and right leg was slightly warm. He had chest congestion and felt short of breath. So the chest x-ray was taken and he was diagnosed with right lower lobe pneumonia and a right pleural effusion. They put him on antibiotics. They were giving him Brovana, Duoneb, and Comavent Respimat PRN. They also doubled his Lasix. They were going to do an ultrasound in the right lung to see if they needed to perform a thoracentesis. The patient had informed me that he had had a right pleural effusion drained about a year ago as well. His respiratory history, he has OSA, COPD, and asthma. He does have some smoking history. Patient quit smoking in 2016. He said he only smoked a couple cigarettes a day. The patient occupation, he was in home improvement, so possible exposure to chemicals and dust and things like that. His past medical and surgical history, cardiac catheter, sepsis, defibrillator, CHF, rectal surgery, hip arthroplasty. He had a replaced pacemaker, AFib, arrhythmia, coronary artery disease, diabetes, obesity, hypertension, and ventricular tachycardia. With his basic assessment, skin color was normal, temperature was normal, sensorium, all that, everything was normal. He did have some accessory muscle use, and his chest expansion was asymmetrical due to the right side having that pleural effusion. It wasn't expanding as much as the left was. He did have some edema in his legs. His heart rate was 69, respiratory rate 14, SpO2 89% on room air, blood pressure 134/87, and temp 36.7 Celsius. Breath sounds, they were clear but diminished, especially on the right side with the effusion. I said that they did match for the pleural effusion part, but the rest of it not really, but he wasn't necessarily having any problems that day, such as like a COPD exacerbation or anything with his asthma. I also didn't hear a pleural flexion rub, which can be associated with pleural effusion. These were pretty consistent for the last 48 hours. They started treating him with a little more medication. He told me he only used a Symbicort inhaler at home, so he wasn't using any other bronchodilators. Something that surprised me was when they doubled his Lasix, he was still retaining a lot of fluid. I think one of the possible reasons he was continuing to retain fluid was due to his CHF. This is because when someone has CHF, it increases the interstitial fluid due to the high pulmonary capillary pressure. Also, another reason could be from that he did fall at home, and this caused him to have a laceration on the right side of his chest. It could have slowly developed, especially because he probably wasn't moving around as much. So his labs, his ABG, 7.5, 44, 57, and 34, acute metabolic alkalosis. His sputum CNS, normal upper respiratory flora with moderate white blood cells, few epithelial cells, but there is no organism seen. I was thinking his ABG was due to the fact that he does have diabetes. And they did end up draining his pleural effusion, but I never got to see the results for that. If the results would have been exudative, this would have been due to his fall. Exudative pleural effusions are usually caused by kind of external factors such as infections or trauma. So that could have been caused by that. But if the results would have been transudative, this would have been caused by his CHF. A transudative pleural effusion is caused by systemic factors like CHF or low protein count, which then causes the fluid to leak into the pleural space. So his chest x-ray, I didn't get a picture of it, but there was fluid in the right lower pleural space and patchy infiltrates. And the right lower lobe, along with some atelectasis. There was also fluid overload in the vasculature, blunted costophrenic angle. The MD interpretation just said continued atelectasis with moderate pleural effusion in the right lung base and mild cardiomegaly. The CXR was getting worse over the next few days as fluid was continuing to accumulate into the pleural space. Kind of some connections for that. The patchy infiltrates due to him having pneumonia. The blunted costophrenic angle and fluid accumulation are due to the pleural effusion. Atelectasis is most likely caused by both the pneumonia and the effusion. He's not really taking those deep breaths either, especially with that pleural effusion going on. Some of the changes, he was having his shortness of breath was going away. His temperature had gone back down with the meds they were giving him. They put him on antibiotics. When I saw him, it was actually his last day of antibiotics, so he was pretty much just in there to keep an eye on that pleural effusion. So some suggestions, I would suggest that the patient loses weight and becomes more active. Him losing weight would take strain off of his lungs with his other underlying conditions, especially having a lot of heart problems. I also suggested that he start taking the Combivent Respimat at home, maybe as a PRN medication, since he told me he was only using his Symbicort inhaler. I thought maybe this might give him some more relief, especially if he wants to be more active. I don't know if that was maybe the reasoning behind it, that he wasn't so active as if he got short of breath. I think they could try a pleurodesis with him if he continues to get pleural effusions. Pleurodesis is a procedure where they inject medications into your lung via a chest tube. This causes swelling in between the two layers, and it helps the lungs stick together to the walls and kind of help stay inflated. Some of the medications that he was on, so they were giving him the Combivent Respimat, the Duoneb, Brovana. He was on furosemide for his Lasix. Of course, he was on insulin. He was also on Atrovacin or Lipitor for high cholesterol. And the dilatium, sorry, I'm very bad at pronouncing these, for his high blood pressure, his hypertension, and his chest pain. And I thought maybe the expected outcome within 2 months, the patient's condition should continue to improve once they do drain his pleural effusion. I know they did end up doing that. Definitely keep an eye on it. Probably keep him on the Lasix just because of his CHF. His other diseases, like an outcome in a year, his disease process, I don't think they'll necessarily continue to improve, such as his COPD, his OSA, CHF. We can control his symptoms with all the medication that he takes. That's why I kind of suggested the PRN medication. But I'm not sure if the patient will end up losing weight. I think he's kind of just stuck in that rut of not being very active. I know he did walk with a cane as well, so that could be a reason why he isn't active as well. I'm sure he will slowly continue to decline, especially with his age and just all of his other comorbidities. So some of the expected patient presentation, I got this from our pathology book, would be fever, chills, shortness of breath, cough, having increased secretions, chest pain, nausea, vomiting, fatigue, crackles, rhonchi. So that was a lot of it for pneumonia, the pleural effusion, shortness of breath, that pleural friction rubbed, diminished breath sounds. But his actual presentation, he did have increased shortness of breath, breathing issues, some hypoxia. His temperature was 100.8. He had chest congestion, a mild runny nose, non-productive cough with wheezing. When he first came in, I think his respiratory rate was 18 and his pulse was 91. I think they did have him on some oxygen initially when he first came in to help with his shortness of breath. This patient was previously on oxygen. A couple months prior, he was hospitalized for pneumonia, I think again, and he had been put on oxygen, but he had passed the test before he went home, so he wasn't wearing that anymore. Most of his labs were pretty normal. His glucose, that was 133. Everything else, his white blood cells were 10.44 within the normal range, which I thought was a little surprising, especially since he had pneumonia. And I do think that his pleural effusion was probably caused by his CHF. I'm sure that the fall didn't help that, but just to the fact that he's already had one before and is just kept continuing to retain the fluid without any relief, and the fact that they doubled his Lasix, I think that he just kept retaining to the fluid and it was backing up in there. Some of my sources I had from uwhealth.org, nijjcardio.org, and then the Egan's textbook along with the pathology textbook. So yeah, and that was my case study.